The following presentation is brought to you by the Terrorism and Disaster Center at the University of Missouri. The Terrorism and Disaster Center is funded by the U.S. Substance Abuse and Mental Health Services Administration and is a partner in the National Child Traumatic Stress Network. This presentation was developed by Dr. Carol S. North from the VA North Texas Healthcare System and the University of Texas Southwestern Medical Center. Dr. North's presentation discusses the mental health response to community disasters. Technological advances have not led to the eradication of major disasters from the world. Rather, failures of modern technologies have created new opportunities for disasters, as evidenced by their roles in myriad transportation accidents, structural collapses, chemical explosions, and large-scale terrorist acts in recent years. Technological advances have also increasingly enabled up-close, on-scene media coverage of massive catastrophic events around the world, focusing attention on affected populations and the need for effective community response. Morbidity and mortality statistics associated with individual disasters in recent years have registered in the hundreds of thousands. In such catastrophic situations, profound mental health consequences can be expected. Based on empirical study of disasters, several main principles of disaster mental health have been established and described in the disaster mental health literature. These principles provide general guidance for clinicians to address mental health effects of disasters. The first guiding principle of disaster mental health is that people are resilient. In efforts to identify mental health problems to be addressed, it is easy to overlook the resilience of the majority who do not develop psychiatric disorders, even after exposure to severe disaster trauma. Some people may even experience personal growth or have other positive outcomes. The second principle clarifies that even though most people do not develop psychiatric illness after exposure to disaster trauma, most people will experience at least some emotional distress. Thus, emotional distress after exposure to disasters is normative and a normal response. Intrusive memories and hyperarousal symptoms are particularly common manifestations of emotional responses to disasters. Distress not meeting criteria for a psychiatric disorder is important and may benefit from psychosocial interventions. There are more opportunities to assist disaster survivors with distress than with psychiatric illness because distress is far more prevalent. The third principle is that one size does not fit all for survivors of disasters, and some people may develop psychiatric disorders after exposure to disaster trauma. It is important to differentiate emotional distress from psychopathology, because different interventions are required for these two different entities. The fourth principle identifies the need to identify psychiatric disorders and provide appropriate treatment for them. Psychiatric disorders developing in the wake of disasters deserve formal assessment and treatment, just as in other settings. Accurate diagnosis is essential because it determines the most appropriate type of intervention. A parallel example in the care of medical illness is that patients presenting to the emergency room with chest pain will benefit from an accurate diagnosis before the administration of definitive treatment. Because chest pain caused by a heart attack requires very different care, such as cleaning coronary arteries from clots, than that indicated for chest pain, which may present with identical symptoms, but be caused by, for example, pneumonia, which would be treated with antibiotics, esophageal spasm, which could be treated with anti-esophageal reflux medications, heartburn, which could require antacids, musculoskeletal pain, which could require non-steroidal anti-inflammatory agents, or a panic attack, which would be treated with psychopharmacologic medication, such as benzodiazepines or antidepressant medication. The fifth principle is that post-traumatic stress disorder, or PTSD, is usually the most common psychiatric disorder to develop after exposure to disaster trauma. A corollary is that PTSD is a conditional diagnosis based on sufficient exposure to a qualifying traumatic event. In other words, people who are not exposed to trauma, according to DSM-5, by physical endangerment, directly witnessing others being endangered, injured, or killed, or by having a close associate who was exposed, cannot be candidates for a diagnosis of PTSD. PTSD usually develops quickly after disaster exposure, within the first few months, and it is often chronic, lasting many months to years. PTSD is usually accompanied by other psychiatric disorders and often medical illness. Avoidance and numbing systems are less common than intrusive memories or hyperarousal symptoms and are markers of risk for PTSD. The second most common diagnosis is usually major depression. This diagnosis, unlike PTSD, may develop even in people without trauma exposure. For example, in people who experience loss of valued possessions or economic losses. PTSD or any other psychiatric disorder is never normal, even if it occurs in relation to a disaster. Diagnosis and treatment of psychiatric disorders is indicated. The sixth principle is that new alcohol and other drug use disorders do not regularly commence after disasters. Although substance use may increase in some groups after certain disasters, this occurrence does not regularly translate into new substance use disorders. Public health expertise has been incorporated into the emergency and medical preparedness and response to disaster. It is also important to integrate mental health into emergency and medical preparedness and response to disaster. Although mental health has not routinely been specifically included in emergency and medical preparedness, examples of successful deployment of mental health operations in conjunction with general disaster response are known. One example of mental health integration in disaster response was the establishment of a mental health specialty unit as part of a general medical clinic providing acute medical care to evacuees of Hurricane Katrina at a large evacuee shelter in Dallas, Texas in 2005. This cooperative effort between medical and mental health caregivers in the community was so successful that the process was repeated in Dallas shelters housing evacuees of Hurricanes Gustav and Ike in 2008. An important lesson learned in these operations was that along with the trauma-related mental health issues expected to emerge after disaster exposure, there was a substantial need for treatment of pre-existing psychiatric disorders endemic in the population that evacuated to the shelter, such as schizophrenia, bipolar disorder, and alcohol and other drug dependence that required the expertise of emergency psychiatry physicians. Another example of mental health integration in disaster response was described by a group in Georgia that produced a county bioterrorism response plan. This plan integrated mental health into the operations sector of an incident command structure to organize resources and orient relationships among public safety departments and other agencies. These examples have demonstrated the need for inclusion of mental health into emergency and medical response to disaster, and the role of psychiatric expertise in coordination with the emergency and medical parts of the operation. A systematic review of mental health response to community disasters, published in the Journal of the American Medical Association in 2013 by North and Pfefferbaum, provides an overview of disaster mental health response and a framework for disaster mental health response. Material to follow in this presentation follows direction provided by this report. The essential elements of emergency and medical response to mass casualty incidents involve three main activities: search and rescue, acute stabilization and triage, and definitive medical treatment. Application of these elements to mental health functions in disaster response translates into identifying psychiatric disorders and mental health needs, triage and referral, and providing appropriate mental health services and interventions. These functions serve as a framework to organize and guide disaster mental health responses. This framework of mental health response to disaster in the 2013 JAMA article by North and Pfefferbaum, shown here, presents the essential elements of disaster mental health response in a flowchart with a decision algorithm over time in the early disaster aftermath. The slides to follow will cover the essential elements in detail, one at a time. In this framework, the mental health evaluation begins shortly after the disaster and proceeds over time. The timeline depicted here indicates the first several weeks after the disaster, and different aspects of the case identification evolve over this time frame. The case identification phase begins as soon as individuals begin to present with emotional and mental health responses to the disaster. The first determination in case identification is whether the individual was exposed to disaster trauma. For individuals exposed to disaster trauma, assessment for PTSD is indicated. For individuals not exposed to disaster trauma, assessment for other stressors and stressor-related disorders is indicated. Individuals presenting with pre-existing psychiatric problems or with a psychiatric crisis after the disaster represent additional concerns to be addressed. The DSM-5 Criterion A for PTSD is used to define trauma because the diagnosis of PTSD, the most common psychiatric disorder after most disasters, depends on having had sufficient exposure to a qualifying trauma. In short, trauma is the experience of threat to life or limb. There are three main ways to be exposed to a qualifying trauma in a disaster. 1. Being directly endangered in the disaster. 2. Being an eyewitness to others being killed, injured, or endangered in the disaster. And 3. Having a close associate, such as a nuclear family member or close friend, who was killed, injured, or endangered in the disaster. A fourth way to qualify for trauma exposure is to experience repeated or extreme exposure to aversive trauma details. Examples are first responders collecting human remains, or police officers repeatedly exposed to details of child abuse. Exposure through electronic media, TV, movies, or pictures does not qualify unless this exposure is work-related. Seeing news coverage of a disaster without personal exposure or any loved one involved would therefore not qualify. People with qualifying trauma exposures in the disaster should be monitored for development of PTSD and acute stress disorder. Evaluation for these disorders will require examination of full DSM-5 diagnostic criteria. If the number of exposed individuals is prohibitively large to permit full diagnostic evaluation of them all, given the available resources, a screening tool may be used to begin the process. Treatment decisions should not be made based upon a positive screen. Those who screen positive will require triage to full diagnostic assessment and referral to interventions or services depending on the results. Assessment for PTSD or acute stress disorder are not needed for people without qualifying exposures to trauma in the disaster. Because PTSD is usually associated with comorbid psychiatric disorders, assessment of people with PTSD should include evaluation for other psychiatric disorders. Major depression and anxiety disorders may also occur after exposure to disaster trauma, and people who lose loved ones may experience bereavement. Because time is required for new psychiatric disorders to develop, PTSD cannot be diagnosed until a month after the disaster, and major depressive disorders until 2 weeks after the disaster, according to DSM-5 criteria. Thus, different types of assessments will be required in different timeframes. Disasters also create stressors that affect people in ways other than through trauma exposure, such as with property destruction, economic losses, separation from loved ones, disruption of social networks, and inconveniences such as impassable roads, traffic congestion, and closure of favorite stores and recreational locations. These stressors may be associated with the development of major depressive disorder or anxiety disorders. Although alcohol and other drug use disorders do not regularly commence after disasters, those with pre-existing substance problems may be at risk for exacerbation or relapse, and any individuals with escalation of substance use after disaster may be at risk for a substance use disorder. Thus, monitoring of these individuals for excessive substance use may be appropriate. The psychiatric disorders to be identified after disaster are those related to trauma, such as conditional trauma-related disorders, including PTSD and acute stress disorder, along with other stressors, such as major depressive disorder and anxiety disorders, and losses, which include bereavement. Diagnosis of post-disaster disorders varies according to the time frame. PTSD cannot be diagnosed until after a month has passed from the time of the disaster, but acute stress disorder can be diagnosed between 3 days and 1 month after. It takes 2 weeks of qualifying symptoms before an episode of major depressive disorder can be diagnosed. Pre-existing psychopathology may recur or be exacerbated after disasters. Some disasters disproportionately affect lower socioeconomic groups who may have substantial amounts of serious mental illness and long-standing substance dependence. An example of this situation occurred with Hurricane Katrina evacuees who were exposed to the storm and evacuated by bus to shelters in Texas. Many of these evacuees arrived at the shelter without their medications and no access to their usual medical care. Mental health services to this population required assistance for serious mental illness, such as schizophrenia and bipolar disorder, and specialized services for substance dependence, such as methadone maintenance treatment. Especially in large evacuee populations, there is always potential that some individuals may develop a psychiatric crisis. Suicidal or homicidal ideation, acute exacerbation of psychosis, psychiatrically based inability to care for oneself or one's dependents, withdrawal symptoms, and acute mental status changes, such as delirium, require urgent evaluation and management, and may result in transport to emergency care and hospital facilities. This part of the flowchart demonstrates decision points in the triage and referral process. In essence, this diagram shows 3 main indicators of need for referral to formal mental health services: active psychiatric disorder, request for mental health services, and psychiatric crisis. Any of these conditions may require triage to formal services. Individuals without any of these conditions may be triaged to psychosocial interventions. Individuals triaged for psychosocial interventions should be monitored for psychiatric decompensation, such as the development of psychiatric disorders or acute psychiatric crisis. Continued observation during psychosocial interventions is needed because some may decompensate and require re-evaluation for triage to services. Others may develop a psychiatric disorder over time, and others may request mental health service. Individuals who develop psychiatric disorders, present with an acute psychiatric crisis, or request mental health services should be referred for formal mental health services. Finally, those who receive formal mental health services may also benefit from supplementation with psychosocial interventions, such as psychological first aid. Triage and referral to services depends on accurate mental health evaluation, as described earlier. This helps to ensure that mental health interventions provided will be appropriate for individual needs. Individuals with a positive screen for PTSD or depression will need further psychiatric evaluation with full diagnostic assessment to inform the most appropriate choice for treatment. Effective treatment decisions are fundamentally based on full diagnostic assessment. Brief acute care for psychiatric stabilization may be needed, such as management of acute exacerbation of serious mental illness or prescription to resume previously established psychotropic medication, before referral to ongoing mental health services for individuals without ongoing sources of care in the post-disaster setting. Individuals in psychiatric crisis may need EMS transport to hospital facilities. Referral for professional evaluation and treatment is also appropriate for anyone requesting referral to mental health services. There are 2 categories of disaster mental health interventions: psychosocial interventions and formal mental health services. Psychosocial interventions include psychological first aid, psychological debriefing, crisis counseling, and psychoeducation. Formal mental health services include assessment and treatment of both pre-existing and trauma-related psychiatric disorders with standard treatment methods, such as psychotherapy and pharmacotherapy. The most effective disaster mental health interventions are those directed to needs identified by accurate mental health assessment. Formal psychiatric treatment is appropriate for post-disaster psychiatric disorders. Wellness and resilience-based psychosocial interventions are indicated for emotional distress and social problems. Because only a minority of even the most highly exposed survivors of disasters will develop a psychiatric disorder after the disaster, psychiatric treatment will not be needed for them. Most people exposed to disasters will experience psychological distress to varying degrees, even if they do not develop a post-disaster psychiatric disorder. Early and continuing psychosocial interventions are therefore generally indicated for disaster survivors to address common distress, provide emotional support, inform, and normalize common emotional responses. The most used psychosocial interventions described in the academic literature are psychological first aid, psychological debriefing, and crisis counseling. Psychological first aid is a collection of practical interventions and principles to address emotional distress. Developed from expert consensus, this practice has not been empirically tested. Psychological first aid can be delivered flexibly in diverse settings to individuals experiencing emotional distress after disasters, by clinicians or non-clinicians. Parallel to medical first aid, the goals of psychological first aid are to assist with basic physical and psychosocial needs, address psychological distress, promote return to adaptive functioning, and direct individuals to appropriate levels of care. Components of psychological first aid are providing a calm, comforting, and compassionate presence, addressing essential physical needs, protecting individuals from further harm, gathering relevant information, including specific concerns of affected individuals, responding appropriately to psychological responses of affected individuals, delivering accurate and timely information about disaster-related risks and responses of authoritative bodies, providing social support and coping assistance, and linkage to social and psychiatric services. A number of available psychological first aid toolkits describe the procedures in detail. Several of these toolkits are listed on this slide. Psychological debriefing is an intervention involving individual or group sessions in the hours or days after a traumatic event to provide emotional ventilation, trauma processing, and psychoeducation. This practice has gained extensive international popularity in spite of a lack of empirical evidence of its effectiveness. Critical incident stress debriefing is a manualized type of psychological debriefing that is widely used. Provision of psychological debriefing does not constitute a full mental health response to disaster mental health needs. For example, this technique does not prevent or treat PTSD. Individuals at risk for PTSD or other psychiatric illness may worsen with debriefing and should instead be identified and referred for psychiatric services. Crisis counseling is a brief, strengths-based intervention that can be delivered to individuals or groups by crisis workers and paraprofessionals in non-traditional community settings, such as disaster shelters. Crisis counseling provides support, understanding of personal emotional reactions, assistance with coping and decision-making, and linkage to services. This intervention has many elements in common with psychological first aid to help survivors with psychological distress after disaster. These psychosocial interventions are not adequate for psychiatric illness that arises after disaster, which requires formal treatment. For disaster survivors receiving psychosocial interventions, continuing vigilance is needed to identify the development of new psychiatric illness and refer it for complete evaluation and appropriate treatment. For those who develop a post-disaster psychiatric disorder, effective treatment is selected appropriate to the identified psychiatric disorder. Standard treatment of trauma-related disorders and symptoms is indicated. For PTSD, usual treatments include psychotherapy, especially trauma-focused cognitive behavioral therapies and exposure-based therapies. Standard treatment is also recommended for major depressive disorder, anxiety disorders, and pre-existing psychiatric disorders. and pharmacotherapy, especially serotonin-specific or other selected antidepressant agents, and pharmacotherapy targeted for specific post-traumatic symptoms, such as sleeplessness, nightmares, and anxiety. Psychiatric expertise should be available for assessment and acute management of pre-existing serious mental illness, such as psychiatric and bipolar disorders, substance abuse dependence and withdrawal symptoms, along with psychiatric crisis, such as suicidal or homicidal ideation, and acute mental health status changes, such as delirium. Additionally, psychosocial interventions such as psychological first aid may provide additional comfort after disaster to those with psychiatric illness. In conclusion, the mental health response to disaster is best integrated into the broader emergency and medical response. Effective mental health response to disaster is fundamentally based on accurate assessment of mental health needs. Mental health assessment begins by addressing exposure to trauma and other stressors related to the disaster, and must include full evaluation of diagnostic criteria for psychiatric disorders for selecting appropriate treatment. Appropriate interventions are selected individually based on the results of mental health assessment, formal treatment for psychiatric disorders, and psychosocial interventions for psychological distress. Psychosocial interventions, such as psychological first aid, may be helpful for psychological distress, but disaster responders must be vigilant for the development of psychiatric disorders after disaster that must be identified and referred for formal treatment. Thank you for viewing this presentation. For more information, please visit the Terrorism and Disaster Center's website at tdc.missouri.edu.